So, as James said, I'm one of the paediatric emergencies physicians here at Starship. I do have some slides here at Starship. And what I wanted to do this afternoon was just talk a little bit about paediatric head injury and a number of questions on paediatric head injury that we're very interested in at the end that we see. And it's something that Dave and I were talking about today as well. And part of the work that I'm going to present comes from the PREDICT Research Network. Now, PREDICT stands for Paediatric Research and Emergency Departments International Collaborative. The international is a bit of a stretch because really it's just Australia and New Zealand. But what it does involve is we started with just the tertiary children's hospitals, and now we're a network of 58 hospitals with over 100 researchers in those 58 hospitals. And the important thing about that is 80% of the children don't present to places like Starship or the Royal Children's or Lady Cilento or whatever you're calling it this week. They actually present to a lot of the smaller hospitals. So we need those people to be engaged in our research if we're going to have really meaningful findings and particularly meaningful translation of our findings as well to kids who present to hospitals. So what I wanted to present today was a little bit of work that we've done on mild and moderate head injury, looking about who to scan. So who of all the children to come in should we give a CT scan? How important is vomiting as a symptom by itself? And then what next for local consensus around this topic? So I want to start with a case. So this little 5-year-old girl was riding her scooter. It wasn't one of the Lime scooters. It wasn't actually a motorised scooter like this. It was her own little scooter. But she'd forgotten her helmet. She was wearing her pink beanie, and she fell off her scooter. She hit the concrete. She cried instantly. She got up. She had a big chuck. She had another couple of vomits, and that's now where you see her in the emergency department 2 hours later. She has a Glasgow Coma score of 15 out of 15. She's got a big frontal hematoma, and the question is, do we give her a CT scan? Should I be using the mouse? Sorry. It's a picture of my daughter, so it's a nice picture to look at. So how common is head injury? Head injuries are incredibly common. 2% of under 5s present each year to emergency departments with head injury. 1% of older children present each year to emergency department with head injury. And the vast majority of this head injury is mild or moderate. Yet we shouldn't forget that in paediatrics, head injury is the leading cause of death and major neurological disability amongst the children that we see. So what's my job in the emergency department? My job is to really identify whether there's any intracranial lesion there. And that's because it's potentially life-threatening, and obviously the need to involve the neurosurgeons as well. However, these injuries are actually pretty uncommon. So they're less than 5% of all the kids that we see with head injury, and actually the neurosurgeons needing to actually touch the children is less than 1 in 200. And the investigation of choice is obviously a CT scan, as I alluded to. But there is cost associated with undertaking a CT scan. There's lifetime mortality risk because of the radiation exposure. In the young children, we need to use sedation, and that carries a risk. And obviously, there's a cost to the healthcare system. We can't scan everybody. And a little bit about the radiation dose around CT scans. The initial studies on these were looking very much at the atomic bomb data. But it doesn't really take a rocket scientist to work out that this doesn't equal that. So what are the risks associated with a CT scan? And we've got better data on that over the last 5 years. And this is a large study that came out of the UK looking at 17 years worth of scans. And for children less than 10 years of age, the risk of having a malignancy in the next 10 years is 1 in 5,000. That's 1 in 10,000 leukemias, 1 in 10,000 brain cancers. So each CT scan we do has a cost for children. So how do we work out whether she should have a scan or not. So when all this work started about a decade ago, this is data that came out of Canada. And these were from 4 paediatric emergency medicine hospitals, which were very similar to Starship. And they asked people like me, could you identify which children had an intracranial lesion? And they identified 72 children. But unfortunately, they were only right in 8% of cases. So people like me are pretty crap at working out who should get a CT scan. So in order to help people like me, what have been developed are clinical decision rules, which help us to delineate who should actually get a CT scan and who should not get a CT scan. And these are really important in terms of balancing that risk of radiation and sedation versus finding what we're really interested in. And this is work that comes from our group. And there are over 20 of these rules internationally. But there are 3 high-quality rules. There's the Chalice rule, which is probably what the current Starship guidelines is based on. And that comes out of work in the northeast of Queensland, the northeast of the UK in the early 2000s. There's the Pecan rule from the US, which involved over 33,000 children, and a rule called Catch from Canada, which involves nearly 4,000 children. The problem with all these rules is they ask different questions. Chalice says who to scan with a head injury of any severity, and this is what's led to the NICE guidelines. Pecan says who not to scan, not who to scan, but who not to scan. And then Catch says who to scan, but only if you've got signs and symptoms. They all have different inclusion and exclusion criteria. They all have different age limits. They actually all have different outcomes. And importantly, none of these rules have actually been externally validated outside of the population that they were derived in. So that makes it a real problem when I'm trying to work out which of those children that I want to scan. So we undertook a study, it was published last year, and it was known as the AFIRST study. And this was to assess the accuracy of those 3 clinical decision rules. And we did it in a number of ways. We did it in the way that the rules were designed, and then we had a very large cohort of essentially everyone who presented to those hospitals with a GCS of 13 to 15, and we compared the 3 rules at that stage. And 10 hospitals were involved, Starship and Middlemore here in Auckland, and the other 8 in Australia. We looked at all head injuries which came in the door in all paediatric ages. And our primary outcome, and I'll talk a little bit more about this, was how good the rules were. So the sensitivity, which is how good the rule is at determining whether there's intracranial injury. The other thing we're really interested in is specificity. And what that does is how good is it to say that you don't need a CT scan. And so if you have high specificity, so if your specificity is 80%, that means that you only scan 20% of the children. Where if your specificity is 5%, that means that you scan 95% of the children. So obviously we're aiming for something higher than that 20%. And we looked at a number of secondary outcomes as well. We followed the children up who didn't get a scan with a telephone call in the next 3 months to find out whether they had gone on and sort of died, whether they'd gone on and got a CT scan elsewhere. Remember, we're not very good. So this is what happened. We enrolled, or there were eligible patients, 22,000 patients. We had difficulty in chasing 2,000 of those patients. So we ended up with over 20,000 patients in this study. But if we look at those 3 rules, so the Pecan rule, and you'll see this in all the slides that go forth, is actually split into 2 rules, one that's less than 2 years and one that is greater than 2 rules. The Pecan rule was only eligible for 75% of the participants in that study. The Catch rule was actually only eligible for 25% of the participants in the study, where the Chalice rule was eligible for 93% of the participants in the study. So this is what those kids look like. And they look like what we see every day. Their mean age was 5. A third of them were female. Boys do worse. It was all associated with falls, as Ian was talking about. And the vast majority of those children had a GCS of 14 or 15. So, you know, children that you're a little bit worried about, but children that you're not automatically going to go and get a CT scan on. So this is the CT scanning rates for the 4 studies. So for our study and the other 3 studies. And I'll talk a little bit about this later on. So in Australia and New Zealand, we scanned about 10% of the patients that we saw in that study. In the US, they scanned 35% of the patients. In Canada, it was 50% of the patients that came through the door. And in the UK, in the early 2000s, where it was pretty hard to get a radiologist out of bed, that was 3% of cases. So this slide shows you the primary outcome for the study. So down the side there is the sensitivity, so it's how good it is at picking the patients that we're interested in, the specificity, the positive predictive value, and the negative predictive value. So all rules performed very well as they were defined. So in PCAN, in the less than 2-year-old age group, they picked all their patients with clinically important traumatic brain injury. In the older cohort, they picked 97 out of 98 patients with clinically important traumatic brain injury. In the Canadian rule, they picked 20 out of 21 patients who required neurosurgery. And in the UK rule, they picked 370 out of 401 who had significant intracranial injury. If you look at the specificity of the rules, the specificity of the US rule was about 50%, where the specificity of the Canadian and the UK rule was 80%. So less children scanned in those other 2 rules. And the negative predictive value was very, very high for all the rules. This is probably the most important slide because this is looking at over 19,000 children who had a GCS of 13, 14 or 15 who presented within 24 hours of their injury. And so this tells you which rule is best. And you can see that in the PCAN rule of the 160 patients with clinically important traumatic brain injury, they missed 1. 13 patients were missed in the Canadian rule and 12 patients were missed in the Chalice rule. And the outcome for this was being ventilated in hospital for more than 24 hours, being admitted into hospital for more than 2 days, or having neurosurgery or dying. So something that everyone in this room will say is a pretty significant outcome from your traumatic brain injury. And that was just looking again at the specificity of the rules. So it was in 50% for PCAN, where it was greater than 70% for the other 2 rules. So that cost, you find more, but you need to do more scans. So in summary, what does this all mean? Well, the sensitivity of all the rules as they're designed is actually very high. PCAN missed 1, CATCH missed 1. If we look at that comparison cohort, PCAN was by far the better rule, picking either 100 or 99% versus 92% versus 93%. Remembering, I don't want to miss any of these patients. And if we looked at the secondary outcomes, and I didn't show you the data for those things, that's exactly the same as well. But the problem being that the specificity of the PCAN rule, so the number that you scan is actually higher, which means that the specificity is lower. And the problem is, our baseline rate in Australia and New Zealand is 10%. So we might adopt the PCAN rule and potentially increase our CT rate for little clinical gain. So what does this mean for this girl? What about her who presents to the emergency department, who's had 3 vomits? What does that mean in terms of scanning her? And if you read the head injury literature, there's a lot written about vomiting. And Meredith Borling and a number of the rest of us looked at this in this cohort study of 20,000 individuals. And what we found is that vomiting occurred in 17% of patients. There was no difference in terms of your risk of having clinically important traumatic brain injury if you vomited less than 3 times or if you vomited more than 3 times. So the number of times that you vomited didn't worry. And then of the 106 children who presented like the little girl in the case that I was talking about, who had isolated vomiting and no other predictors of traumatic brain injury, there was only 1 patient who had clinically important traumatic brain injury. And in the study, you've got to look at a number of details around these missed patients. And when you look at it, the only reason they were defined as having clinically important traumatic brain injury is that they stayed in hospital because of their brain injury for more than 2 days. So they didn't have neurosurgery, they didn't die. So what do we need to do about all of this in Australia and New Zealand? Well, we've done some qualitative research where we've gone out and asked people on the floor, what do they want us to do? And they very clearly said that they need some guidance in order to step through all these things. They want information on all the special groups, and I haven't delved into any of that, but NAI, kids who have got shunts in their heads, kids who have got bleeding disorders, what to do with them. They're particularly interested in who to neuroimage and also what to tell the juniors in terms of neuroimaging. And importantly, they want clear advice about what to do around concussion as well. So the way that we plan to do this is to develop a Trans-Tasman guideline in paediatric acute care of head injury, focusing very much on the AFIRST data and a number of other sub-studies that we've done. We'll do this with a very wide multidisciplinary group, which involves both paediatricians, emergency doctors, radiologists, neurosurgeons, people from across both countries and across the states and territories, in order to go through this in a systematic approach, based on other guidelines that are out there and also review of the literature as well. So hopefully I've given you a brief overlay of some of the work that we're doing in paediatric head injury. The take-home points, PCAN has the greatest sensitivity. So if you're going to use any rule, use the PCAN rule. Isolated vomiting by itself really is associated with clinically important traumatic brain injury. And hopefully by this time next year, we'll have an Australasian guideline, because as Ian was talking about earlier, it's by working together and having common systems that will reduce mortality and morbidity. So there are a number of people who are involved in all this work. Jocelyn Noitzi led the study at Kids First. We were funded locally by the Auckland Medical Research Foundation and the A+ Trust. Franz Babel led some of the work from the Royal Children's Hospital in Melbourne, and Meredith Borland from what's now the Perth Children's Hospital.